how are you going to know it's infiltrated? And how are you going to be able to chart it? How are you going to be able to describe it? Because remember, somebody's probably going to be following you. You want to see if it's getting worse, if it's getting better, right? So there's a 1 to 4 scale that you're going to use, and 1 is what you want. 1 is there's no swelling, there's no pain, there's no redness, there's no warmth. It looks good. No phlebitis. No infiltration. 1, you've got the skin is blanched, which means when you press down on it, you pick up, it doesn't go back to being a little bit pink. If there's less than 1 inch of edema in any direction, it's cool to the touch with or without pain. And then as you move down the scale, you have progressively more problems. So I'm going to let you take your time, because I can rattle it off to you. Not going to mean anything to you. You need to take some time and look at the differences between 0, 1, 2, 3, and 4, measured out. Try to figure it out. We'll do our best to make this interesting for you in the lab. That's how I'll put that, okay? You want a 0 infiltration score. You also want a 0 phlebitis score. Because remember, infiltration is it's leaked into the tissue, and phlebitis is we've got an infection in the tissue. We've got damage to the tissue. If those scores aren't 0, you're going to have to take out the IV. No matter what it looks like to you, if the patient says it's painful, it's painful. You're going to have to look at it. You're probably going to have to take it out. Check and see if it's in the bend. Look and see if it, sometimes when it's in the wrist, there's a lot of nervation in there, a lot of nerves. So sometimes it's moving in the vein in a way that's causing it to touch up against the nerve and causing problems. So we're not trying to hurt our patients. If they're okay with you trying to sticking them again, try to find a different IV site so that you can move it. Phlebitis scale, again, 0 is going to be nothing. It looks great. There's no redness. There's no heat there. A 1, it's a little red. They're not complaining of anything, but it's looking a little red. So we're going to kind of be a little concerned about that, okay? Redness is one of the signs of infection, right? So figure out, why is it red? Did somebody just put it in a freckle? Was it red when they put it in? Look at their original note, see what's going in. 2, you're going to begin to have pain at the site, as well as redness and maybe some swelling. So I'm going to, again, this is another one. I'm not going to go through each level. It's on the slides. It's in the video. Stop it, pause it, look over it, see the differences between the levels, study it up. Make sure that you understand what's going on, because you're going to need to chart it. If it's a 4, you don't want it to stay at a 4, right? After you take it off, you want to see it begin to back off. So if it was at a 4 phlebitis scale whenever you took out the IV, and 4 hours later the next nurse comes in behind you, she shouldn't see that it's still at a 4. Maybe the tip came off. We're going to talk about that in a minute too. Maybe there's another problem there. It should be beginning to be less red, less swollen, less hot. The cord should be getting smaller, because by the time you get to 4, you've got a palpable cord, which means you can feel it. It's just like a hard, long knot going on in there. You've done some real damage, not you. The IV has had some real damage done to it, that vein. So as it begins, 4 or 5 hours later, that should be not so palpable. It should be not so very plain. So if it's infiltrated, what are you going to do? How are you going to know what's happening? Well, the catheter's dislodged, or the vein is deteriorated and enabled it to leak, and fluid is infusing into the surrounding tissue. So one of the first signs you're going to see with that one is edema, right? It's going to get big. I've seen Popeye, all right? You have to check that IV site. You should round on your patient every 1 to 2 hours. Most facilities are kind of pushing for you to see your patient every hour. Every hour when you go in there, glance that IV. You don't have to take a magnifying glass, but look at it. And if one arm is huger than the arm that's huge is the one that has the IV, that's probably not a good thing. If they've got edema, if they've got pallor, which is paleness, if the skin is getting cooler, usually IV fluids are at least room temperature. They're not usually any warmer than that. They may be cooler than that, depending on when they were hung. room temperature is cooler than your body because your body's 98.6, right? Most people would like be sweating to death in a room that was 98.6. So it's cooler than your body. So if the area of your body feels cooler, and maybe because that fluid is leaked into the tissues. And they're usually going to be, it's painful, right? Because it's pushing that tissue out, it's dislodging things. The nerves are getting all upset about it, so it's going to be painful. So you're going to stop the IV, you're going to elevate it because gravity works, right? So if you elevate it, it's going to get it back into circulation by getting it away from that site. And follow the policy considering treatment. Some drugs will cause real damage to the tissues that they infiltrate into. They will just really start destroying stuff. Hergert, it could cause a mess. A lot of chemotherapy drugs, the whole reason they're getting them is to destroy tissue, right? Destroy growth. So they're going to destroy things. Usually you don't give chemotherapy peripherally. In fact, I don't know of any chemotherapy drugs that you give peripherally. Those are pretty much always in a central port so that they're in those bigger vessels. But there are other drugs that are just really irritating. So you need to let the doc know what was running. So that means you need to know what's running. That's another reason why you follow up the tubing and see what's going on. Let him know what was running and let him know what your scale is on your infiltration so that he can decide what, if anything, he needs to do. If it's saline or lactated ringers or dextrose, those things are not going to damage the skin. You just put a warm compress on it, elevate it, let him know that it's infiltrated, and you've put a new IV in and it's running. But it's nothing that I would call him at home at midnight to tell him. Extravasation is a little bit different from infiltration. Extravasation causes infiltration, but with extravasation, it means that the catheter is actually migrated out of the vein and it's pouring it into the surrounding tissue. So that's what it means. Extravasation means it's come out of the vein. And they're going to have pain, stinging, burning, swelling, redness. Again, you're going to want to follow your agency policy, follow the facility policy, discontinue the IV, but now you want to put in a cool compress. A little bit different. If the medication has an antidote, it's going to be administered. And it can cause tissue death and severe complications. That's kind of what I was talking about with the infiltration. It kind of, it's more medication related than it is anything else. Why you have to address it, why you have to find it and fix it. What's going in and what can I do to make it not terrible. And that's what you need to know about assessing an IV. If you have any questions, that's why we have Piazza. Please feel free to ask. Or you can text me, or you can ask in class. That's another reason why I have you watch these before you come to class. If something's not clear, talk to me. We'll help you figure it out. Or go look it up and come and say, you know what? It said this, but this is what I found in my research. I will be so thrilled. All right. You have a blessed day, and I'll see you in class.